Welcome to the February installment of the Dutch webinar series. My name is Dr. Kelly Roof, and I am a clinical educator here at Dutch. In today's session, we're excited to welcome Dr. Tim Hyatt, one of our clinical educators here at Dutch. Dr. Hyatt will explore the role played by estrogen and testosterone therapy in heart health as it pertains to cardiovascular disease. Dr. Hyatt received his doctorate in naturopathic medicine in 2006. He brings a broad range of skills and perspectives from years of clinical practice and currently serves as a clinical educator for Precision Analytical in McMinnville, Oregon. His medical interests include endocrine function, neurochemistry, and physical medicine. Dr. Hyatt is also the president of Biogenic Nutrition, a nutraceutical company specializing in unique condition-specific formulas. If you're ready to start using Dutch testing in your practice, sign up as a provider today. Just click the link that we posted in the chat and complete our provider application form. A member of our onboarding team will walk you through the steps to set up an account so you can begin to take advantage of all the education and resources that Dutch has to offer. Plus, registered providers gain access to the Mastering Functional Hormone Testing course, the Dutch Interpretive Guide, the Introduction to HRT course, and one-on-one consultations with Dutch clinical educators. This dedicated support and education is designed to help you become the hormone expert. And if you have any questions as we go, please submit them and we'll do our best to address them in a follow-up in the days ahead. So be sure to follow us across all social platforms to stay up to date. It's a pleasure to have you with us, Dr. Hyatt. Take it away.
Thanks so much, Kelly. It's great to be here. Today, I'm excited to talk about the role of estrogen and testosterone therapy in heart health. Just wanted to say a quick thank you to all the team here at Dutch. I couldn't have done this webinar without them, and this has been a great experience. So let's go ahead and get started. Cardiovascular disease was one of the #1 killer of men and women in the United States in 2020. And the process of aging is a major factor in declining cardiovascular health. Here at Dutch, we focus directly on hormone testing, but in the functional medicine space, we're trained to incorporate all the aspects of function, including cardiovascular health. Today, we want to look at how hormone health plays a role in cardiovascular function, especially in aging individuals, and give you some things to think about when it comes to hormone replacement therapy and testing. We want to include this slide just to let you know that this is for educational purpose only. It is not medical or treatment advice. The use of this information in this presentation is solely at your own risk. Today, we're going to take a brief, high-level look at cardiovascular health and the connection to estrogen and testosterone. Then we'll dive into estrogen's impact on women's health, followed by testosterone's impact on men's health. And at the end, we'll mention some important things to think about as we wrap it up. I will admit that after doing research for this webinar, I'm going to sound like a fanboy for HRT for both men and women because I'm now convinced of the importance of both hormones in the process of aging and specifically how it pertains to cardiovascular health. Some brief statistics on cardiovascular disease here. CVD accounted for 578,000 deaths in the United States in 2020. The risk of death from CVD has increased about 1% per decade since 1990. And the major risk factors include family history, age, smoking, diabetes, overweight and obesity, hypertension, poor sleep, inactivity, poor nutrition and diet, lipid status, genetic factors, and inflammation. Looking at the 4 categories of cardiovascular disease, we have cerebrovascular disease, which is reduced blood flow to the brain caused by thromboembolism, aneurysm, or ischemia. Coronary heart disease, which is reduced blood flow to the heart due to buildup of plaques. Peripheral artery disease from thrombus, embolism, or atherosclerosis resulting in reduced blood flow, and aortic atherosclerosis caused by buildup of plaque resulting in reduced blood flow in or rupture of the artery or of the aorta. When we look at sex hormones and cardiovascular health, estrogen and testosterone both have been extensively studied to support the following in the cardiovascular system. We're going to be looking at endothelial function and inflammatory response, the microbiome, blood pressure, insulin production and sensitization, and body composition. So what do we know about aging and inflammation? We know the processes of aging and inflammation dramatically increase the number of cardiovascular events. Hormone levels decline with age, which coincides with a decline in health. Hormone replacement therapy in aging men and women have beneficial effects on cardiovascular health. So if we look at cardiovascular health and estrogen in women, we're going to look at cycling females and look at the levels that they have in the serum. Daily production in cycling females is variable. Concentration in circulation is 30 to 400 picograms per mil. Contrast that with postmenopausal females. We have a daily production at 18 micrograms per day, and the concentration in circulation is 0 to 10 picograms per mil. Here we have a comparison of Quest Diagnostics versus Dutch test levels of estradiol. On the left, the Quest ranges comparing pre versus postmenopausal levels. On the right, the Dutch test ranges. And this might be a good time to mention here at PA, we submitted a study that established correlation of estradiol in serum with our method of collection and testing on the Dutch test. And this study was published in a peer-reviewed journal, and you can find that link on our website if you want to see how that was done. On the left, we have a cycling female level for luteal phase. This is page 3 of the Dutch test. On the right, we have postmenopausal female levels. You can see on the left, those cycling levels are going to be up there in the luteal range up above that star on the left. And on the right, those postmenopausal levels can be quite low. Biochemical effects of estrogen. Estrogen or estradiol mediates its effects via 3 receptors: the E2 receptor alpha, the E2 receptor beta, and the G protein coupled E2 receptor GPER. This is a nice graphic that provides some clarity about the biochemical effects of estradiol. In each case, E2 binds the receptor, and the estrogen receptor complex moves inside the cell after binding. It is the destination of the complex inside the cell that makes the difference in how estradiol works. On the left, the complex moves into the cytoplasm, where we see the non-genomic effects, and these happen within minutes. In the middle, the complex translocates into the nucleus, inducing changes through transcription that have effects within hours to days. And then on the right, we have the mitochondrial localization, where we see both genomic and non-genomic effects resulting in mitochondrial biogenesis and improvement in mitochondrial function. This slide shows the role of the loss of estradiol. At the top, we see that 17-beta estradiol loss, which results in changes in the vasculature and in the mitochondrium, or myocardium. On the left, we have a decrease in enzyme nitric oxide synthase, increase in apoptosis, increase in ECM deposition and vessel stiffness, vessel constriction is increased, and vessel dilation is decreased. So in the myocardium, we get left ventricular hypertrophy, ECM deposition, stiffness, apoptosis, inflammation, and then decrease in vascular tone. All of these result in hypertrophy. A quick look at the structure of an artery wall. As a reminder, we've got the endothelial layer inside the artery, that first layer. A very thin layer. This is where a lot of the effects of estrogen occur, along with in the smooth muscle. This slide looks at endothelial breakdown And inflammation caused by these factors leads to endothelial breakdown. It's dyslipidemia, hypertension, insulin resistance, type 2 diabetes, obesity, and perceived stress, which results in an increase in cortisol. Now, the inside of the blood vessel, we didn't show that on a couple slides ago, but we have this glycocalyx. Glycocalyx is a protective layer on the inside of the artery. It's usually, if we look on the right here, we can see that this is a healthy glycocalyx. It's usually fairly thick and very protective. If we go from the right to the left here, we can see that there's damage that has occurred to the glycocalyx, and the layer is very thin. So once we lose that, and get damage to the glycocalyx, it damages the endothelium, leaves it more vulnerable. And then we end up with leaky blood vessels, LPS translocation, LPS-induced oxidation, oxidative stress, immune activation, foam cell formation, and end organ damage. So in the endothelium, we have some effects from estradiol. And if we look at this, sex hormone receptors are found in immune function, endothelial, and vascular smooth muscle cells. Estradiol increases nitric oxide production. It decreases endothelin-1, a potent vasoconstrictor and pro-inflammatory peptide secreted by the endothelium. It has direct antioxidant effects where it scavenges and inhibits reactive oxygen species. It increases mitochondrial antioxidant defense. Estrogen receptor A is a key factor here too in maintaining endothelial vascular function, where it increases eNOS and superoxide dismutase. It modulates endothelial cell ER expression, which impacts ER signaling, sensitivity, and function. And in premenopausal females, E2 increases HDL cholesterol and it reduces LDL cholesterol. And lastly, estrogen modulates inflammatory cytokines IL-1B, IL-6, and TNF-alpha and reduces inflammation through stimulation of anti-inflammatory cytokines, IL-4 and IL-10. So inflammation is the key driver during all stages of the atherosclerotic process, from initiation through progression, and ultimately leading to thrombotic complications such as MI, CVA, ischemic limb, DVT, and PE. By reducing inflammation, estradiol reduces endothelial damage. Now, if we look at the estrogen in the microbiome, the gut microbiome regulates circulating estrogens via the beta-glucuronidase mechanism. And beta-glucuronidase deconjugates estrogen to their active forms. Dysbiosis results in less beta-glucuronidase secretion and lower levels of available estrogen in the postmenopausal years. This may contribute to the development of conditions discussed herein: obesity, metabolic syndrome, cancer, endometrial hyperplasia, endometriosis, PCOS, fertility, cardiovascular disease, and cognitive function. This graphic shows us how gut dysbiosis influences reproductive syndromes and conditions. And at the top in the middle, we can see the lack of microbial diversity and changes in ratio of gram-positive to gram-negative bacteria. This is connected with estrobolome dysfunction and eventually disrupts estrogen metabolism. This change in estrogen metabolism influences the process of endometriosis, PCOS, and endometrial hyperplasia, also obesity and metabolic syndrome, along with cancer, and it can affect fertility as well. In addition, there's a strong connection between gut health and brain function that cannot be ignored here. And this is a full lecture and a huge topic of interest right now in functional medicine. So how does estradiol affect blood pressure? It increases prostacyclin receptors and nitric oxide production to improve vasodilation. It decreases angiotensin II, resulting in lower blood pressure. It inhibits vascular smooth muscle cell proliferation. In vitro, estrogen exerts a direct inhibitory effect on smooth muscle by activating potassium efflux and inhibiting calcium influx. How about estrogen and blood sugar? If we look at the effects of estrogen on blood sugar, estrogen provides protection and facilitation of insulin secretion and function in the control of glucose availability to tissues. It modulates the energy partition, favoring the use of lipids as the main energy substrate when their availability is higher than that of carbohydrates. It also provides functional protection through antioxidant mechanisms. And there are some central effects on the body, energy metabolism, and homeostasis maintenance. And here's an important key point. Estrogen provides sustained control of core energy metabolism. If we look at this slide, it's a visual of how the accumulation of white adipose tissue through excess energy intake leads to obesity. We can see the inflammatory cytokines produced here. That local inflammation kind of reaches a point where the maximal load is exceeded, and then we end up with systemic inflammation and insulin resistance and metabolic syndrome over time. This slide is showing the process of aromatization in adipose tissue. In the plasma, we see androstenedione, DHEA, DHA sulfate. Those are move into the fat tissue from the vascular system. And DHEA is converted to androstenedione and then down to estrone through aromatase. On the right, we can see androstenediol being converted to testosterone and then down to estradiol. And these are interconverted through those 17-beta HSD enzyme systems. When it comes to estrogen and body composition, E1 is the predominant estrogen in menopause, but it can be converted to E2 in the adipose tissue. Adipose tissue is the main peripheral site of estrogen production, and this is accomplished through aromatization. And then due to much higher E2 secreted from the ovaries in premenopausal females, peripheral aromatization is not a significant source of E2 after menopause. Also, 90% of postmenopausal E2 comes from DHEA. Now, the adipose tissue deposition is mainly in gluteal femoral regions in perimenopausal years, but it moves to visceral deposition after menopause. And the mechanism for this, we don't know what that is, but it is thought to involve many mechanisms around aging in the ovaries, resulting in lower levels of sex hormones, and metabolic changes that favor deposition and help maintain postmenopausal levels of sex hormones. Now, the process of aging, increasing chronic inflammation, and the decline of sex hormone production are thought to be the major players in the deposition of adipose tissue, resulting in significant changes in body composition, leading to challenges in the normal function of the cardiovascular system. So, premenopausal versus postmenopausal risk for CVD, we have premenopausal at the top. The CVD risk for cycling females with normal cycles is pretty low. CVD risk for patients with PCOS, primary ovarian insufficiency, is increased when compared to patients with normal cycles. If we contrast that to postmenopausal patients, estrogen, progesterone, and testosterone levels will decline significantly, and metabolic risk factors such as hypertension, weight gain, insulin resistance, diabetes, and therefore CVD risk is increased. In menopause, Both age and biological sex play a role in the development of cardiometabolic disturbances. And the frequency of cardiovascular disease before the age of 55, shortly after the onset of menopause, is lower in women than in men. And lower levels of estrogen in menopause are associated with a higher level of cardiovascular disease. So if we look at CVD for age and sex, gather demographics and health data from the UK Biobank. This was a study done by a group in China. They looked at 226,000 participants for 12 years. And what they found, they looked at a mean age of 55 years, males 47%, females were 52% of the population. There were multiple CV outcomes measured against modifiable and socioeconomic risk factors and age. And these are some of the results. If we look, we see the risk for CVD outcomes was higher for men at all age groups. And you can see those numbers here compared to the percent outcomes for females. Metabolic health was by far the most influential modifiable risk factor in this study for both sexes. Hypertension was the largest contributor, accounting for 14% of the population attributable risk percentage, followed by abdominal obesity, 9.5%, and there was a significant higher CVD incidence in males compared with females, 11.2 versus 5.88. So conclusions drawn from both studies cited at the bottom of the page show that females are more protected than males because of estrogen. Premenopausal women have a decreased risk of CVD compared to their age-matched male counterparts. And at the age of 55, the lifetime risk of cardiovascular disease for males and females is similar. Males are more likely to suffer from a coronary artery disease as an initial event, and females are more likely to suffer from cerebrovascular disease or develop heart failure. The lower frequency of premature coronary artery disease, PCAD, in premenopausal women compared to men is primarily due to the protective effect of female sex hormones. So what is MHRT? Let's take a look at this. Menopausal hormone replacement therapy is replacement of estrogen, progesterone, and testosterone during postmenopausal years. If we're using replacement therapy, providers must consider risk factors for breast cancer, cardiovascular health, bone health, and risk for dementia prior to onset of therapy. Using bioidentical forms of hormones and staying within physiologic levels may reduce risk for adverse events related to initiation of therapy. And the time of initiation of therapy is really important. We must consider lifestyle changes to minimize risk of mortality as well. And taking a functional, holistic medical approach improves the likelihood of success. So if we look at the WHI study, the Women's Health Initiative study, just a little summary here. In the 1990s, the WHI followed over 68,000 women ages 50 to 79. Women with a uterus were given oral conjugated equine estrogen, that's CEE, plus medroxyprogesterone acetate, or MPA, or placebo. And women without a uterus were given oral CEE alone or with placebo. Bioidentical estradiol was not used. The goal of the study were to determine outcomes for these study groups. And the goal was to investigate whether oral CEE or without MPA was effective prevention for common health concerns such as coronary heart disease and osteoporosis-related fractures in postmenopausal women. Now, the conclusions from the WHI: MHRT has been found to be safe with rare CVD risks, especially when started in women less than 60 years old or less than 10 years from the onset of menopause. The formulation of estrogen and progestogen therapy also affect the cardiovascular risk. Oral E2 or transdermal E2 and oral micronized progesterone show even less venous thromboembolism risk than when compared to oral CEEs or plus MPA. And the health of the patient at the time of initiation of HRT is important, like I've said earlier. In a sub-analysis of women who were 50 to 59 years old and less than 10 years since menopause, risks were rare and benefits were more significant. And there's an increased VTE and stroke risk reported in this study is thought to be due to first-pass metabolism with oral delivery of hormones. So it's the oral hormones there that are problematic. Now, if we look at the effects of oral estrogens, they increase liver production of the following proteins: SHBG, blood clotting factors, thyroxine binding globulin, so TBG, or CBG, which is corticosteroid binding globulin. It may also influence higher production of high-density lipoproteins, HDL cholesterol, and then lower production of LDL cholesterol through bile excretion. Now, the basic contraindication for the use of oral estrogens in the context of CVD risk is that oral estrogen should not be considered in women with a moderate to high calculated 10-year risk, which is in between 5 and 10%. This slide shows the 10-year CVD risk in menopause is low, which is less than 5%, moderate, which is 5 to 10, and high, which is greater than 10%. An effective way to understand your 10-year CVD risk is to use the ASCVD calculator in the link here. Some other considerations: transdermal estrogen therapy has not demonstrated increased VTE and stroke risk, which is likely due to bypassing liver metabolism. But it has not been well studied as oral estrogens. Switching to transdermal estrogens and oral bioidentical progesterone reduces both the benefit on the cholesterol profile and the thrombogenic risk. And transdermal E2 and oral micronized progesterone show some cardiovascular system benefits. If we look at HRT with estradiol, we start with oral. Oral is the most studied form, and this was used in the WHI study. First pass effect is a bit problematic for some patients, and the oral forms, many of the oral forms are synthetically derived. There are some, obviously you can get estradiol orally, but there's a lot of synthetic forms there. Transdermal, well studied for effectiveness, and for some conditions, very few published studies, and this form includes the estradiol patch and creams and gels. Transmucosal, this could include oral, vaginal, or rectal applications. It's used less frequently, and it has variable local and systemic delivery that we need to consider. Percutaneous is a pellet delivery system used in patients who want consistent delivery without having to pay daily attention to administration. Not much of the data on pellet therapy at this point, though, and so it is more popular, is being used more frequently, but not enough data yet. If we look at the last intramuscular, less frequently used. I don't have a whole lot to say about it. I haven't seen it used much at all here at Dutch or in practice. So some considerations when using estrogen therapy in postmenopausal patients. Estradiol decreases cardiovascular morbidity and mortality. Caution is advised in patients with high stroke risk, VTE risk for all estrogen therapy. The health of the patient at the time of starting MHRT and their individual risk factors should be reviewed, and health status is really important. E2 therapy has been found to support a healthy cardiovascular system through maintaining vascular elasticity and endothelial function. Recently, postmenopausal women, depending on cardiovascular risk, Those with a subclinical ASCVD may require higher serum E2 levels, closer to the low luteal range, which is 40 to 60 picograms per mil, or validated transdermal dried urine levels of roughly 1.8 to 2.0 nanograms per milligrams of creatinine. Older postmenopausal women or women further from menopause onset probably do best with serum E2 levels just outside of that postmenopausal range, 20 to 40 picograms per mil, or validated dried urine levels of 0.7 to 1.3 to 1.5 nanograms per milligram, regardless of cardiovascular disease risk. And the time since menopause and age greater than 60, for those patients, we should consider risk stratification, but not preclude MHRT initiation or continuation. And ongoing risk stratification and follow-up testing is a must for all women. Key point to remember, we need to remind patients that estradiol is not indicated to prevent adverse cardiovascular outcomes. However, the data suggests that it will improve cardiovascular disease outcomes, and the earlier you initiate therapy, the greater the benefits. Testosterone. Let's switch and talk about males and testosterone. If we look at production, males produce about 3.7 plus or minus 2.2 milligrams per day. LabCorp published ranges here you can see below, ages 40 to 79. And the range goes from 156 up to 916 at the highest level. The ideal functional range for total testosterone in males is 500 to 1,000 nanograms per deciliter. In circulation, testosterone is loosely bound to albumin, 30 to 45% is bound, and more strongly bound to sex hormone binding globulin, roughly about 65%, with a small fraction, 1 to 3% circulating as free testosterone. So, testosterone functions. In males, most of the testosterone is produced in the gonads, binds to androgen receptors throughout the body, interacts with progesterone, estrogen, and androgen receptors, regulates early brain development, cognitive function, social interactions, sexual development and function, stimulates connective tissue, maintenance, and repair. And as we'll see, it has important effects on the cardiovascular system. So the four areas we'll talk about are going to be endothelial function and inflammatory response, blood pressure, insulin resistance, and body composition. Now, we can look at testosterone deficiency and its effects on vascular mechanisms. The process of aging leads to endothelial dysfunction, which is at the heart of CVD. As we talked about earlier in the estrogen section, we get a large artery stiffening from endothelial breakdown. We also get functional changes in the vascular smooth muscles of the arteries, resulting in less vessel compliance and increased blood pressure. Increased inflammation and reduced nitric oxide and reactive oxygen species also contribute. These vascular changes and inflammation result in left ventricular hypertrophy, diastolic dysfunction, changes in the efficiency of the heart, along with more endothelial injury, further increasing the risk of a cardiovascular event. Inflammation is the key driver during all stages of the atherosclerotic process. And this is due to aging and other factors such as dyslipidemia, hypertension, which is in part that mechanism is angiotensin II release. These things cause generation of reactive oxygen species and pro-inflammatory cytokines. When it comes to testosterone and endothelial dysfunction, healthy middle-aged men with low testosterone appear to have greater age-associated endothelial dysfunction, related in part to greater oxidative stress and inflammation. And many studies have confirmed that low testosterone concentrations may contribute to accelerated vascular aging in men. Low testosterone leads to endothelial dysfunction specifically, and testosterone modulates the inflammatory cytokines much like estrogen does, the IL-1B, IL-6, and TNF-alpha. Those are the inflammatory cytokines, and then increases the stimulation of anti-inflammatory cytokines, IL-4 and IL-10. Testosterone is also considered to be an independent determinant of endothelial dysfunction. Here are some cardiovascular and renal effects mediated by estrogens. A few highlights here, keeping in mind that some of these were animal studies. And one we haven't mentioned yet is the effect testosterone has on sodium and water reabsorption in the kidney. And we'll talk about that in a second. But at the top, some of the effects on the heart itself, influencing adrenal receptors, sodium-calcium ion exchange, and calcium channels. Some points about blood pressure and testosterone. Small studies show that higher testosterone levels are correlated to higher blood pressure. Androgens have various effects on both vascular and renal tissue, which result in hyper, hypo, and normotensive effects. Hypogonadism is associated with lower nitric oxide output, resulting or leading to less vasodilation and higher blood pressure. Androgens regulate sodium and water balance via the renin-angiotensin system. And if we look at this study, very interesting study here, this was a multi-center, it was published in the Journal of American Heart Association. There you can see that at the top. This is a multi-center, population-based, cross-sectional study of 6,296 men conducted between 2013 and 2016. They measure blood pressure, plasma levels of total testosterone, sex hormone binding globulin, luteinizing hormone, and also free testosterone. And they determined in a multi-stage random cluster sampling in 6 provinces in China. There were 5,786 Chinese men. Mean age was 55. And after exclusion criteria were applied, 37% of the patients were diagnosed with hypertension. And the results showed that free and total testosterone and sex hormone binding globulin were inversely associated with the prevalence of hypertension. For those men ages 65 and older, or for those with a BMI greater than 24, they saw a negative impact on the inverse correlation between testosterone levels and hypertension. In addition, smoking and family history of hypertension strengthened the correlation. In participants with grade 2 hypertension, total testosterone was positively associated with the presence of stroke, and luteinizing hormone was also positively correlated with cardiovascular and cerebrovascular diseases. So the conclusion for testosterone and blood pressure is lower total testosterone could be a promising risk marker for prevalent hypertension. Number 2, both low and high levels of testosterone were associated with greater cardiovascular risk. And number 3, primary hypogonadism may be a risk marker for major cardiovascular diseases in men with severe hypertension. So here's the point. If you're a male, it is really important to know if your testosterone levels are normal for age, especially if you're hypertensive. Now, what do we know about testosterone and insulin? Testosterone acts on the androgen receptor in the beta cells to enhance glucose-stimulated insulin secretion, which is GSIS, by potentiating the action of GLP-1, that glucagon-like peptide 1. Low serum testosterone levels are associated with an adverse metabolic profile and can independently predict the increase in insulin resistance. But the testosterone administration in men with low or low normal testosterone levels does not improve insulin sensitivity. The molecular basis of functional deficiency in androgen receptor signaling and the pathophysiology of developing obesity and insulin resistance remains unclear. How does testosterone work in the pancreas? This graphic shows how DHT binds to the androgen receptor. It migrates into the cytoplasm after binding, activates the second messenger systems involving cyclic AMP and protein kinase A, which results in insulin release. And it also shows how it interacts with GLP-1. And this is kind of neat because there is a connection between insulin release and higher levels of alpha androgens, which can be a problem in hyperandrogenic states, especially in females. This is a mechanism that is good to keep in mind for those females who have higher androgen levels. Now moving on, we have a picture that shows how testosterone influences pancreatic beta cells in both males and females, and there are some big differences here. In males, here on the left, testosterone increases GLP-1, it increases GSIS, and reduces inflammation and promotes beta cell health. On the flip side, in females, excess testosterone promotes hypersecretion of insulin, mitochondrial dysfunction, oxidative stress, and B cell failure, which predisposes them to diabetes. The slide just simply reiterates how androgen deficiency ties in with obesity, metabolic syndrome, diabetes, and insulin resistance through beta cell dysfunction. So let's take a quick look at a study where Vermeulen et al. Looked at testosterone and body composition. In this study, they looked at 372 males greater than 20 up to 85 and measured body fat by impedance. Total and free testosterone levels were looked at in plasma, and they looked at insulin as well. Using multiple regression analysis, they found that testosterone decreased from 598 in the younger controls to 453 in the elderly group. Free testosterone decreased from 15.35 to 8.38, respectively, and fat-free mass decreased by 18.9%. In a subgroup of 57 men aged 70 to 80 years, testosterone correlated negatively with body fat percentage, abdominal fat, and plasma insulin levels. The conclusion from this study: BMI and age were independent determinants of testosterone levels. In elderly men with low T prior to treatment, there was an increased lean body mass and mid-arm circumference and a decrease in waist to hip ratio. Aging is accompanied by an important increase in fat mass and a decrease in lean body mass. And there's an age-associated testosterone is a determinant of the changes in body composition. Another study here, Goodale et al. Looked at TRT, and in a summary of research through 2017, they concluded after age 40, there's a decline in testosterone that's associated with an increased risk in all-cause mortality. Low T in men may increase the risk of developing coronary artery disease, metabolic syndrome, and type 2 diabetes. There are no large long-term placebo-controlled randomized clinical trials to provide definitive conclusions about TRT and cardiovascular disease risk. So, testosterone replacement therapy, we have see some improvement in myocardial ischemia with men with coronary artery disease. It improves the exercise capacity in patients with CHF, and it improves serum glucose levels, HbA1c, and insulin resistance in men with diabetes and prediabetes. So for testosterone replacement therapy, the forms of delivery are oral, which is FDA approved for men but not for women, IM injectable, This form is most frequently used for males. It is, we have short and long-acting preparations depending on what the patient needs. Sub-Q injectables, which are used once a week. Transdermal gels, creams, and pellets. This is the most frequently used form for females. Daily dosing closely mimics physiology, and it is a good form to consider in some cases. Pellets are increasing in popularity, and these have a nice steady delivery system. And the advantage, again, is that you don't have to pay attention to those. Once you put them on, they're there. Intranasal is another form, and these daily use will reliably raise levels within physiologic norms. TRT may produce a wide range of benefits for men with hypogonadism, and some of the benefits you can see here: libido and sexual function is improved, bone density, muscle mass, body composition is improved, mood, red blood cell production, erythropoiesis, cognition, and overall quality of life is improved. This systematic review of 393 studies showed that in hypogonadal men with type 2 diabetes, significantly improved on testosterone replacement therapy. And they observed that testosterone administration improves body weight and metabolic factors in men with hypogonadism, but withdrawal of testosterone reverses those benefits, and those benefits appear again after testosterone replacement is resumed. Most of the studies found that increased testosterone, even over the long term, does not affect the PSA, or its effect is negligible. And among the available treatments, only transdermal gel delivery and long-acting injectable testosterone provide pharmacokinetic behavior that gives a steady state level within a physiologic range. There are some risks that we have to pay attention to, and the big one here is blood pressure. There was a review that showed that looked at a lot of different risks with TRT, and the one for cardiovascular disease. I know this is really small, and you probably can't see this up at the top, but baseline blood pressure checks, repeats at 3 and 6 months, and then annually thereafter are really important. And for high-risk patients, considering cardiology referral would be a good idea. So starting oral testosterone treatment is associated with an increased risk of VTE, or venous thromboembolism. So this peaks about 6 months after the onset of treatment, but it does decline thereafter. So this is an important consideration with testosterone replacement. Now, with TRT, the dose really matters. Those higher doses, or doses leading to high serum levels, are associated with an increase in blood clots, like I mentioned, and stroke risk due to risk of polycythemia. So we need to monitor with complete blood count. And elevated blood pressure and arterial stiffness can be a problem as well. We need to monitor with blood pressure. High doses can cause high cholesterol. We need to monitor cholesterol. And then men with a history of CVD may get worse with testosterone replacement therapy, so we have to think about that as well. Therapeutic goals in males: total testosterone levels in serum greater than 500 to less than 1,000 nanograms per deciliter. That's the goal. Serum E2 levels between 20 and 40 picograms per mil. And we need to remember that serum testing is the gold standard. Now, if we look at some Dutch results, I'm going to look at 2 different results. We're going to contrast them. One's a 58-year-old male with low androgens, and another is a 58-year-old male with high androgens. This first report, you can see these age-dependent ranges over here on the left. We have 5-alpha-androstenediol, 5-alpha-DHT, and testosterone for this 58-year-old male. If we look at the levels, the testosterone is very, very low here at 15. That range is 25 to 80. If we look at the 5-ADHT, 7.7, the range is 7 to 20, and the 5A androstenediol is 50 to 180, and he's at a 66. So we have very low androgens. We also have lower estrogen, thankfully. In older men, it's important to have estrogen that coincides with the level of testosterone. We have increase in estrogen is protective in older males. And so when a gentleman like this goes on replacement therapy, we want to make sure that we're bringing the estrogen is coming up with it, but obviously we don't want that too high either. So he may be a good candidate for replacement. If we look at the 58-year-old with high androgens, in contrast, we can see he has a testosterone of 100, 80 would be the high, and this guy is on replacement therapy, has a high androsterone, probably taking DHEA as well. 5-alpha DHT was 22.5, that's, you can see that's above the range there, and 5-alpha androstenediol was at 218, which is well above the range there. So we have high androgens due to the therapy, and then we have estrone and estradiol that are both eclipsing that high end of the range. So this would be a situation where the provider might want to take another look and adjust dosing to be within a normal range. So a quick summary of what we can take with us. Estrogen and testosterone are important for many reasons outside their role in sexual function. There is a plethora of evidence that suggests inflammation is at the base of cardiovascular disease, and that aging in females usually concomitant with the menopausal state is associated with increased inflammation and risk for CVD. The data suggests estrogen replacement therapy will improve CVD outcomes, and the earlier you initiate therapy, the greater the benefits. Testosterone levels decline with age, and the risk for CVD increases with age. And lastly, testosterone therapy supplemented within normal ranges, 500 to 1,000 nanograms per deciliter in serum, improves many of the metabolic conditions associated with and causative in the process of CVD. References are at the end. You can go ahead and look at those if you want. We thank you for being with us here today and hope that you can get some information from this that's useful to you. And I hope you have a good day. Take care.
Thanks, Dr. Hyatt, for this insightful webinar, and thank you all for joining us today. We hope you learned something that you can take back to your own practice. Watch your inboxes tomorrow for a link to the recording and to access the resources that we shared today. You can learn more about the research behind the Dutch test at dutchtest.com/research, and make sure to visit the Become a Provider tab at dutchtest.com to register for an account so you can gain access to even more hormone education and research. Be sure to follow @DutchTest and subscribe wherever you get your socials to stay in the loop for upcoming webinars and podcasts.